So welcome everyone to today's Grand Round. I'm Neil Hill, I'm one of the diabetes consultants at Charing Cross Hospital, and I've got Harriet Esdaile, who's an SPR in diabetes and endo, and Mike Wride, who's an IMT, and they're going to do a talk about diabetes as of now. So crack on, guys.
Hi, good afternoon, everyone. So we're going to do a talk today, a case presentation, which is a relatively typical case that you might see in hospital, and particularly focus on the sugars management in this patient. So the case is, again, a very typical case that you might see on in AMU or any medical ward. 84-year-old who comes in with a fall. He's been on the floor for about 5 hours and was investigated and treated for urinary sepsis. And he also had an AKI. So he was treated with fluids and antibiotics at the time in the ED. So a bit of history on him. So he's a type 2 diabetic, and he has hypertension, AF, and he's registered blind as well, and has a background of CCF and CKD. So he's got a number of things going on. He's coping relatively well at home, but needs help outdoors, and he needs extra help because he is blind. So here's his medications. He's on a few different oral agents for his diabetes, particularly metformin, gliclazide, and linagliptin. And you can see the rest of his other medications there. And we'll get back to these in a bit. So his blood's at the front door. As we said, he came in full with a long lie, CK 3,400. And you can see the AKI there as well, eGFR 23. Normally his baseline is 44. And he has quite a typical picture of infection with CRP of 240. In terms of his blood glucose, it's 6.6 at the door, and his ketones are 0.9. And his HbA1c is 70. So not perfect glucose control at home with his oral agents. So going back to his medications, we know that he's got an AKI, so we need to think about which medications to hold. So any ideas in the comments of which medications you might hold in this patient with an AKI and sepsis, who is also a bit hypotensive?
If you'd like to unmute yourselves or comment by the comments box just about what would you do with this patient's medication, given that he's got an AKI, so his eGFR is now around 25, having been 44, and he's got a blood sugar at the front door of 14. It's repeated on on a VBG, it's repeated on the ward, and it's now 6. Ketones of 0.9. So has anyone got any thoughts about what they do with his medications?
But yeah, all good thoughts on the chat. So absolutely holding things like ACE inhibitors in AKI, and also looking at the diabetic medications, the metformin and glucoside. And given that he was hypotensive, his some of the antihypertensive medications and diuretics were held as well. So following the case throughout his admission, so on day 1, he was found to have Klebsiella pneumonia, and blood cultures grew Klebsiella, which actually pointed more towards a pneumonia rather than urinary source. But regardless, he was responding well to the fluids and antibiotics, which brings us on to the more diabetic side of things, is that his sugars started to run quite high as an inpatient, and you can see there that screen grab from his Cerner notes, time-wise from right to left, of his hypoglycemia. And then on the next day, he's continuing to improve, a couple of temperature spikes, but otherwise doing well and seems to be responding to the antibiotics. Urine output's good, and his eGFR is quite static at the moment. His blood sugars are still running quite high and have actually gotten higher, as you can see at the 7:30 reading in the evening. He's actually reaching the top of the glucometer in terms of sugars, so they're really running out of control at this point. But fortunately, his ketones are remaining consistently low at 0.1. And on the right of the screen, you can see another screen grab. So that is he was given 2 stat doses of Novorapid for these blood sugars. First one at the first Novorapid at about 6 o'clock. As you can see, it didn't do very much initially, so he was given another 2 units at 7:30, and his blood sugar started to come down.
Okay, so if everyone can go back to Menti, and we'd like you to answer this question. So how much does 1 unit of Novorapid reduce your blood glucose by for the average person? So is it 1 millimole per litre, 2, 3, 5, or 10? Those voting and okay, so a bit of a spread. So the majority of people have said 2. The correct answer is 3 on average. Your 1 unit of Novorapid would not reduce your blood sugar by anywhere near 5 or 10 minimum. Okay, and we can see that this man has already had a few stacks of Novorapid throughout his admission, and actually his blood sugars aren't really budging. So we need to think about other reasons that this man might need a little bit more insulin in order to achieve those blood sugar targets. And we'll talk about that a little bit later on. So back to his admission.
So he's been in for 3 days now, and it's Saturday. And this is, I'm sure a lot of people will recognise this situation, being on call on the wards. You get called 8:30 a.m. and the nurse is concerned that blood sugars have been a bit high overnight, despite a couple of doses of Novorapid. So he's had 2 stat doses of Novorapid overnight, the first being 4 units and the second being 6 units, and his blood sugars are still 25.7 when you see him. So the question is, what would you do at this point?
They've already received those 2 stacks of Novorapid. They've had now about 4 stacks of Novorapid within 16 hours. So would you give further stacks of Novorapid? It's a Saturday, and see if you can hold tight and get a diabetic nurse review on Monday. Would you give a stat Novorapid now with a blood sugar of 25.7 and introduce a background insulin? Would you put him on a variable rate insulin infusion? Would you think about a fixed rate infusion, or would you essentially escalate to a senior review? Okay, so we've got the majority saying that they would go to a variable rate. We've got a couple of people talking about introducing a background insulin, and then 1 person asking for senior review. And just, I wondered if anyone would mind just telling me why they would think about putting this patient on a variable rate next. Just think about sort of clinically, you're there on the shop floor and you're treating this patient. There's sort of no, there's not necessarily a right or wrong thing to do in this patient, although I think there's no, it'd be dangerous to give a fixed rate. But does anyone have any ideas about why they would go to a variable rate? Happy for you to put any comments in the chat box. Okay, so I don't know if you heard that, but the 9 doctors have said that they wanted to do option 2, but would be unsure about how to introduce a long-acting insulin without having had a variable rate first.
Another thing just to say, particularly for juniors, is that if you're really not sure, then insulins can be dangerous in terms of hypoglycemia, giving too much insulin. So if you're really not confident with this, then it's always okay to have a chat with your senior about what you should do, especially in this patient that is struggling with blood sugars.
I think I'd probably start a variable rate in this man at the moment, because we don't know what his basal requirements are. He's not normally on insulin, he's still sick. And although we could give him a background insulin, I think it'd be quite tricky to know the right dose to begin with. You could start with 10 units of a long-acting insulin like glargine, but that might take a while to work, and you'd have to have a clear plan for giving additional PRN doses of Novorapid, which is achievable, but requires a fair amount of intensive nursing and medical work to do so.
If we were to introduce a background at this stage, which background would you go for? Would you think about a long-acting, something like Lantus or Levermere, would you think about intermediate acting humulin I? Okay, so that's interesting. So there's a bit of a spread there. The majority of you have said intermediate acting, and the rest long acting and pre-mixed. So I think introducing a background here, probably you would want to introduce either a long acting or an intermediate acting. I think, would it be fair to say with pre-mixed, you may run into difficulties. And I think one of the, again, we can talk about this a little bit later, but so the first thing I guess to say in this situation is you don't have necessarily a feel for how much this patient, or what this patient's insulin requirement is. And the other factor to take into account is that he's got renal impairment now with an eGFR of 25, and it's not, so he's now been here for a couple of days. It's not quite clear how much of that is reversible.
I think, and with a pre-mixed insulin, of course, that's got fast-acting insulin, so something that's going to counter a meal, and some intermediate-acting insulin, which will last for the next sort of 12 to 14 hours. And because he's unwell and we don't know what his food intake is, then it might be quite difficult to judge how much pre-mixed insulin to give and how much is going to deal with any food he eats, and what if he doesn't eat, are we still going to give it? So that's why probably some of the longer acting or intermediate acting insulins, which don't have a bolus component, a fast acting insulin within them, is a better option.
Does anyone have any questions about that? Happy for you to unmute your microphones. We want to make this as sort of educational as possible. So do unmute yourself and ask any questions. No?
I've got a question, Harriet. It's Shivani.
Hello.
A really good presentation. Can you just put up the original slide that gave the background history? Because what was it? He was on oral hypoglycemics with an AKI. Is that it? And unwell.
Yeah. So he had a baseline eGFR of 44, and he was on metformin 500 milligrams twice a day, gliclazide 80 in the morning and 40 milligrams in the evening, and linagliptin 5 milligrams. And he had this, a baseline eGFR of 44 and ejection fraction of about 44%.
And why was he unwell?
So essentially, he had a bacteremia. So he had Klebsiella growing in his blood culture. We never quite identified the source. But he was quite septic when he came in. He was quite hypotensive. He had a good going SIRS response.
Okay, no, I was just sorry, I just wanted to make sure that it's a type 2 picture, right? Because we wouldn't normally start a long-acting analog in someone with type 2, right? So the point that was made about him not eating goes against using a pre-mixed, but the first line should be humulin I, right? Or insulatard.
Yeah, you're right. I think we were just sort of being pre-mixed up there as a potential option. Just to throw that into the mix, but you're correct, there wouldn't really be an indication here to start that.
And also, just for everyone, I mean, these are intermediate acting and pre-mixed insulins are not background insulins, right? Because they don't provide 24-hour coverage. So they are if you give them twice a day, but if you don't, you're not getting a 24-hour basal with intermediate and pre-mixed. Just to raise the point, because you've called them which background, but they're background if you give them twice a day.
Yeah. That's a really good point. Thank you.
Sorry, I've just got a quick question, if that's okay. When he came in, his gliclazide and his metformin, I'm guessing, were completely held. Was there any plan made with regards to what was going to happen re his diabetic control at that point? Or was it just stopped and nothing else started?
Yeah. So initially everything was stopped, and for the first 24 hours, I just go back. So as you can see, these were all, they were held except for the linagliptin, and then we can see blood sugars running on the higher side, and then we'll talk about the gliclazide and the metformin a little bit, but essentially no, there was no formal plan, and then it sort of became Saturday and he had 4 stats of the Nova Rapid, but essentially by day 3 the plan had been to restart the glycoside 80 milligrams and 40 in the evening, which is what he'd been on previously. That didn't actually end up happening, because I think there was still an ongoing concern about his renal failure, because his eGFR was stuck at 25, although passing good volumes of urine. But we can see that essentially he goes on to have, further stats on day 3 of Novorapid, and we can see that actually his blood sugar is not really budging. I'm just going to point out that 27.7 is the highest that we can read here in terms of blood sugar monitoring. And so, yeah, essentially, this man may well have just an uncontrolled hypoglycemia that's much higher than that. So, essentially, yes, day 3, meant to restart glycoside, but ends up having multiple stats of Novorapid and no other insulin is started. So we'll come back to the case. Just thinking a little bit more broadly about the classification of hypoglycemia in acutely unwell patients. So, you've got those patients with no diabetes, so such as in this patient, so that they've been diagnosed in previous to admission. You've got patients with newly diagnosed diabetes, and then you have got a cohort of patients who have hospital-related hypoglycemia, also known as a stress hypoglycemia. And these are patients who have this stress response during their inpatient stay, but their glucose essentially reverts to the normal range just before or after discharge. And I think in this patient, I guess one of the things that I wanted to bring up was, I think, the fact that he was so septic made him really, really insulin resistant. And actually, I don't know if anyone, wants to, I suppose, say anything, but I think here the reason that he was so hypoglycemic wasn't so much an insulin deficiency, but a real insulin resistance, and that's being driven by his neuroendocrine response. So we see this big updrive in sympathetic activity and catecholamine release, but we also get the release of cortisol and IGF-1, and that all essentially leads to an increase in your glucose and an insulin resistant picture. Just thinking about variable rate, so in terms of working out his overall, so if we do think that this man ultimately may well need insulin, and I suppose you could argue at the moment it's, he's had uncontrolled hypoglycemia, he's septic, we want to try, that's making him insulin resistant, but we also want to get better control of his blood sugars, because we know that uncontrolled hypoglycemia and sepsis is not a good thing. So yeah, insulin resistant, septic, that essentially, we may well be now thinking about insulin. So just to mention that sepsis is an indication to think about a variable rate insulin infusion, as is, certain surgical procedures, recurrent vomiting, and other indications. So, and it's also going to be, I guess, the most accurate way to try to work out this man's overall insulin requirement. Does anyone want to add anything to that? And then just thinking about the treatment with insulin for these patients. So on the one hand, it's going to give you a slightly more accurate way of calculating someone's insulin requirements, but essentially, there are lots of trials that have shown that glycemic control with a basal bolus or a basal plus approach is better. In this man, it was slightly complicated by the fact that he had CKD and he also had some pulmonary edema that developed shortly after admission due to the amount of fluid that he received. So you might want to, in that case, then think about a dry sliding scale. But one approach in this patient might have been a basal plus approach, thinking about a single dose of basal insulin at about 0.1 to 0.5 units per kilogram per day, with corrective doses of insulin for increased glucose concentrations before meals or every 6 hours if nil by mouth. And then premixed insulin, as Dr. Misra mentioned, you're only going to get that background coverage if you're giving it twice a day, but generally is associated with quite a high rate of iatrogenic hypoglycemia because it relies on patients eating fairly regularly. So it's not recommended in this scenario. Does that all make sense? Please do comment if you have any questions at the moment. Okay. So if I just hand over to Mike to take us through the case.
Yeah, so there was a plan to restart his glycoside after day 3, but it didn't happen in the end. He had quite a few more stat units of Nova Rapid over the weekend. And then on Monday, he was started on Levermere at a gentle dose of 4 units, which was then brought up. And then we continued to review him and ended up switching him to Novamix.
I just added probably here, may or may not have been the preferred insulin, having said what we said about Novamix and pre-mixed insulin.
So yeah, so contrary to everything else, he ended up on Novamix, and he continued to get better. And you can see that his glycemic control was better throughout the admission at the bottom there, but we still had quite a variable range of blood sugars. Particularly looking in the mornings, you can see at 6 o'clock in 3 subsequent mornings, a relative hypoglycemia, so probably slightly too tight control.
Actually, that at the bottom is him having finished his, so that's
Oh,
his
sorry.
insulin stop, sorry, 10 days after admission. So he ended up on the Novamix BD, and then his infection resolved, his AKI partially resolved, so his eGFR came up to 35, and then insulin was stopped. And then these are his blood sugars a day after, well, 48 hours essentially post stopping the insulin. So not perfect, but nowhere near as bad as they were on admission. And then just thinking about resolution, this was just a nice summary in the notes, about the rationale for the stopping the insulin essentially. So we've noted that his HbA1c is, during this admission is 66, similar to his HbA1c of 70 in October. His current hypoglycemia remains poor after meals as he's recovering from acute illness and therefore insulin resistant, but this will improve over the next few weeks. Essentially, there are quite a few, there's a risk of hypoglycemia on insulin, and given his blindness, essentially, there's an added perhaps complication to sending him home on insulin, and he'll need monitoring in the community. Suggest going back to his pre-admission treatment, and actually, he should become less insulin resistant, and glucose levels will improve over a few days. And arguably, that's what we can see did happen when he stopped all his insulin, having needed fairly high doses at 32 units of the Novamix in the morning and 60 units in the evening. Although
sorry, Harriet, Shivani again. You might have said this because I just popped out of the room, but why was Levermere started?
So I think the rationale for starting Levermere was that it was giving a little bit of longer acting insulin, but I think there was a concern about his renal failure at that point. And I think because I think there was a thought about starting him on a variable rate, but there was a concern he was quite fluid overloaded. Although I guess that could have been given as a dry, sliding scale. But I think the rationale was that Levermere was a safer insulin given his renal impairment, providing some background.
So I think there's an important learning point here, isn't there? And I mean, look, this is a fantastic case. Thank you so much, because it's generating so much discussion. And I think for everyone that's not in diabetes or endo, for those of us in there, we spend a lot of time debating these things. So there's sometimes there's no right or wrong. But on this occasion, there is a right, because the national guidelines state that we shouldn't be using analog long-acting insulins in people with type 2. For example, Levermere or Glargine or Lantus, whatever you want to call it. These insulins are really expensive. And so we have guidelines within the trust and also national guidelines which tell us to use intermediate acting insulin. So something like Humulin I, at a small dose, even though he has an AKI, loads of our patients with chronic renal impairment are on Humulin I and come to no harm, would have been absolutely fine. This is a really big chunk of our patients, and we absolutely shouldn't be giving them analog insulins for background cover when they don't need it.
Yeah, yeah, yeah. I don't know if you want to add anything to that. Okay, so this is something that, am I right in saying, Dr. Hill, you came up with this? So if you want to...
I'll just pop in. I know everyone is slightly overdone with sort of acronyms for various things, but this is one I use a bit just in terms of inpatient diabetes management, and it's not really, I just made it up and I couldn't get the letters and the words to make anything other than hate, and once I got it in my mind, it's kind of stuck there. But it's just something perhaps to think about, which when you're looking after patients who are on the wards with diabetes, which obviously differs from outpatient management. And I suppose in terms of our sort of goals for inpatient management, clearly we want to, I suppose first of all, we want to make sure people don't have a worse experience in hospital than they do out of hospital in terms of their blood glucose management. And I think the other thing to say is we're not necessarily trying to fix their diabetes in hospital. We want them to be safe and well. And so when I'm seeing people, I try and think of these things, which are firstly their HbA1c, if that's available. Of course, it's not always, but it does give you a feel for what their blood glucose levels are pre-admission. So clearly, if their HbA1c is 53, that's significantly different from someone who has an HbA1c of 90 in the sort of pre-admission period. It just gives you a feel for what's going on before they came into hospital. And then the A is what actually are their blood glucose levels. And as Harriet's pointed out, and I'll emphasize time and time again, 27.7 is the upper limit of the glucometers here in the trust. Now, in the past, they used to read HI for high, but they don't now. So I'm aware of cases where people have been 27.7 all day and it's not been twigged. So please just bear that in mind. If it's 27.7, effectively you don't know what their glucose is, apart from the fact it's very high. So in that instance, I would suggest you should be doing a venous gas, for example, which might give you an idea above that range, or a laboratory glucose, just to know where you're at and what you're dealing with. So the T stands for target blood glucose levels, and for most people that will be 6 to 10 millimoles per litre, although the guidelines suggest we could accept between 4 and 12, which seems pretty pragmatic to me. But if people are frail, then I'd suggest slightly more generous targets, so between 8 and 15 millimoles per litre. And these are target levels. It doesn't mean to say every single blood glucose reading has to be within that range, but this is sort of pragmatic and achievable. And you'd want the majority of their blood glucose levels to be in there. And lastly, the EGFR, which again gives you some idea about what oral options might be available for them if they've got CKD or AKI, as well as insulin dosing. So just a little acronym to sort of bear in mind. Thank you.
Okay.
So, and the final thing to say from me, as well as thank you for listening and thanks for all the engagement with the chat, is we're going to be launching this diabetes support quip, I suppose you call it, called TARDIS. And the idea is that we are going to have some diabetes nurses and ideally a diabetes consultant, probably me, available for a Teams drop-in session on Tuesday and Thursday morning. So between 8:45 and 9:15, starting on the 1st of February. So it's going to be Tuesday and Thursday morning, remote diabetes inpatient sessions. And there's a QR code there. We're still trying to work out how to get this more widely available to everyone. But if you have any questions about diabetes or any patients you'd like to discuss, you're welcome to dial in to this and we will try and support you remotely. And if needs be, come and see you. This is something we're trialing for the month of February. So you're very welcome to dial into that.